Thank you, Dr. Rohit, Dr. Tushya. Yeah, thank you for this kind invitation and having me in this wonderful course. Uh, so I'm going to talk about understanding the dynamics of small people. I think it's all about anticipation, identification, and management. I do have a financial interest in the BX People Expander. I'll come to that also. So now, what is the problem with small people? When the pupil size comes down to half, the viewing area for the surgeon is reduced to a quarter. This is elementary geometry, and if the surgeon can't see the cataract, he can't operate safely, and that would be a disaster. So, a simple question that I asked now, it's very, kind of paradoxical, let's say. Dr. Rohit is a very skilled surgeon, and he practically uses no devices. Okay, so but in the same course, we speak about devices. So there is a relevance. So what I would like you to do is ask yourself, we've all burnt our fingers doing surgery without a device, and at some point or the other, or taking a call a bit too late. So if you were the patient on the table and your eye is being operated and you have a 4 mm pupil and you got an excellent surgeon operating, what would you prefer? The surgeon use only his skills or take the help of a device? I think you should have your answer. So can the pre-op pupil be a predictor of IFIS? The answer is a big no. For pupils 7 mm or smaller, the risk of IFIS existed regardless of alpha blocker intake. And that is the list of conditions which can cause IFIS. It is not tamsulosin alone, unfortunately. It's a whole lot of drugs over there. And hypertension, there is a large Indian study which said that hypertension was a very big risk factor, and every patient, alternate patient, is a hypertensive, including the surgeon. So, so no amount of history taking can prevent surprises. Intraop mysis is unpredictable, and let's come to terms with that. Fortunately, surgeons are reducing the threshold slowly. They have backup devices in the theater because of the unpredictability of IFIS and exacting patient expectations. Patient expectations have gone through the roof. And unforgiving nature of premium IOLs. You've planned a multifocal, you've planned a toric, you can't have a small pupil on the table. It's a risk, unwanted risk that you're taking. So I believe a disciplined approach is very important. Treat every eye as a potential IFIS candidate and then start your surgery. So you keep a stock of devices. You don't have to resort to it over time, but at least the fact that you have it in a theater, it makes a difference to your confidence level. Use viscoelastics judiciously. But what is, I think, key to understanding small people is distinguishing the elastic small people from the non-elastic rigid small people. That's something we didn't know about, I think, too much. Courtesy my device and my work over there, I realized over a period of time that there are two different animals completely. So, and how big do you want the pupil to be? Be realistic. We really need a huge pupil, and the choice of pupil device actually very much depends, I mean, whether you want to use an OVD, iris hooks, or pupil expander, the elasticity of the pupil, and how you want to tear the rigid pupil. IFIS, I'm going to tell you that no device actually works for the problems that we have. So, injecting viscoelastic, we have a common tendency as soon as we made a paracentesis, inject a lot of viscoelastic, and let's see how big the pupil dilates. Well, that's the last thing you should be doing, because the moment you inject a lot of viscoelastic, you're plastering the iris to the anterior lens surface, and you're not leaving any space for the device. And that's going to, the AC becomes deep, ergonomically it becomes difficult. So that is the place you need to inject viscoelastic under the pupil margin, and keep the anterior chamber shallow so that you can lift off the pupil margin from the iris, from the lens surface. So keep the AC underfilled. Overfilling is counterproductive. Inject viscoelastic under the pupil margin to create space for the device, whatever you use. So Chang and Campbell in 2005 told us that unlike the non-elastic myotic pupils, the IFIS pupil immediately snaps back to its original size following attempts to stretch it. So small pupils are basically of two types. You can classify them any which way. It's elastic or non-elastic. Elastic pupil is like a rubber band. You can stretch it. Any device will work. Now, the rigid or the non-elastic ones are very much like a string. It's not going to stretch. You need to tear it. So how you wish to tear it is up to you, whether you want to use a bulky pupil expander like the Mulligan or the eye-ring, or you use Coughlin hooks and then use a delicate device like the BX. That's your choice entirely. We can assess the nature of the pupil before we start. As soon as we made the paracentesis, inject BSS or ringal active, whatever you want, and inflate the anterior chamber. Inject BSS to inflate the anterior chamber. You get a momentary expansion, you know it's an elastic pupil. Ye to bada hoga hi. And if it does not, well, it will not budge. And then you know it's a rigid pupil, it's a string. So you need to tear it. So now you take your call how you want to tear it. You don't need to go limbus to limbus tearing it. You need to just tear it for about 5 millimeters. So you get a good cosmetic, good pupil. Post-op, you still have a round pupil. The patient does not have too much of glare. You don't have to be really, too forceful about it. So mechanical dilatation of pupil has no role in IFIS. If it's an elastic pupil, it's going counterproductive. If it's a rigid fibrotic pupil, of course it has. So now how we want to dilate? Iris retractors, hooks, or pupil rings like the Mulligan ring or the B-hex. So I'll just talk about iris hooks briefly. This should start. Yeah. So this is side ports first. I mean, this is a very old video. I've not used iris hooks in a very long time. But then that's the basic principles remain the same. I prefer to keep a conjunctival mark because it becomes very embarrassing sometimes. Otherwise, you can't find the paracentesis because you're making smaller paracentesis. If it's clear corneal, you just can't find it and then keep struggling. I would like to keep that retractor, the stopper, push back a lot. Otherwise, again, it's embarrassing. You put the iris hook inside, then you realize now you have to pull back that stopper. I prefer to make my incisions after I placed all the hooks. And I would like to get a handle on the capsular rhexis size. We tend to get carried away and make a larger rhexis. Stick to your plan about the rhexis size. This is an over-retracted pupil. This is an over-retracted. This was the time when we used to have large ones, And remember that the pupil is at the limbal plane. It's elevated to the anteriorly to the limbal plane, so your space in the antechamber is reduced. Every instrument that you pass is going to knock that iris or the pupil margin, and the pupil margin is often going to be anti-flexed. So remember that. Removal isn't such a big deal. You can use any which way. Just hold that stopper, advance that the hook, and just pull it out. It's very simple. Or you can twist it, turn it however you want. There is a little downside of the iris hooks for the reason, that's the reason why people are moving to pupil expanders. So you may count them as downsides or not, depending on your choice. So there is definitely a theoretical risk of infection with more incisions. Iris sphincter tear is a reality. And you are rendering the pupil a square, which is absolutely a waste of space. You are going to work within the capsular rhexis, and the corners are absolutely wasted. So your anterior chamber is shortened because of the pupil, the iris is to an anterior plane, and there is a chance of iris trauma and corneal endothelial damage. This is a study published in 2019 where it showed that the time taken with iris hooks was much longer compared to a pupil device, expansion device. It's 14 minutes more for consultants and 24 minutes more for trainees. And of course, if you have a permanent dilated pupil, the patient is never going to forgive you. With a multifocal IL, you can be looking forward to a lot of trouble. And the cosmetic issues, of course. You don't like to see your post-op eyes like this on the slit lamp. So the B-hex is a very thin device, flexible, thin notches, strong flanges, and tabs for holding. It's a hexagonal device. It's thinner than the human. It's as thin as the human hair. So it's a simple design, no rocket science, user-friendly, safe, and I believe affordable also. So you need, so it's got a transparent housing, and you have constant visibility of the device in its entire travel, which you don't have with an injector. When you're using an injector, you have no clue what the ring is doing inside with this twisting, turning, somersaulting. You have no clue till it comes out. You need a B-hex forceps to manipulate it and take it into the anterior chamber. Well, a forceps is very easy for all of us to use, and this is an ergonomically designed device. Now, the inventive step or the difference between the Mulligan ring, eye ring, and the B-hex is that all these devices were biplanar devices where the scroll is like this, and the pupil margin is over here. So it's a lot thicker over here, and if you want to push this through a slit incision, it is going to snag that incision and get stuck. And on the way out, it's the reverse, it's going to get stuck. So that's why the injector is there, to circumvent that problem, not to make your injection or placement of the device safer. So the B-hex is very simple, it's intuitive, so it's all in a single plane. The iris bends at the notches. The iris bends. The iris can be bent harmlessly, no big deal about that. So you can take the device into the anterior chamber and bring it out with the forceps. How big do you want the pupil to be? Now, if I were to tell you that this pupil is not going to come down less than 5.5 millimeter, do what you may during the surgery, I think most of us in this room are very comfortable operating. 5.5 is a very good size for all of us. We do a 5 millimeter capsular rhexis, finish off the surgery if you are sure, and that's all you need. So why do you need a 7 millimeter pupil? Even for the hardest cataract, a 5.5 millimeter pupil is good. A larger pupil is actually not very useful. It's only psychological for you. Oh, hard cataract, I need a large pupil. It's just in your mind. So, and even with iris hooks, I think you should stick to a 5.5 size. So let's take a look at this video by Deepak Megor. It's a pretty hard cataract, rigid pupil, stretches it a little bit, and that's the size of the pupil after the B-hex. It's just 5.5, and this is a pretty hard cataract, as you will see. There's no doubt this is a hard cataract. All you need to do is chop it into smaller fragments. That's all, and you can deal with as hard a cataract as you want. Your working space is that's all you need. That's your active working space. So rest of your surgery is easy. Now, IFIS is something which I want to talk about. We all have at one point or time come to believe that, okay, iris looks good for IFIS or pupil expander, X pupil expander, or one more minute for me, is it? Yeah. So, yeah. So, is my best device, is my go-to device. All of us have that in our mind, over the period, because it worked well in one particular IFIS case. Try to go back and think. Now, if you analyze a little more objectively, IFIS, for me, there are two components, meiosis and iris prolapse. Leave the fluttering. Meiosis part, whether you use iris hooks or pupil expanders, all that they do is provide you constant pupil size, good visibility, safe phaco. That's given. Okay, there's no doubt about that. Okay. Now, if you come to iris prolapse, then you go back and think. No device works. Actually, iris prolapse is a function of severity of IFIS. So that day, that eye, what was in your nasib is what matters. And actually, whether the patient was on Tamsulin's for 1 week or 5 years really doesn't matter. Even 1 week can do as bad as 5 years or worse for sometimes. So it's your day, that day, what was your luck, okay? And how you played with the fluidics that day is all. So remember, all you need, get that out of your mind. Iris is prolapsing, let it prolapse. You can see your surgical area. That's what matters. Iris will be a little bit traumatized. I could show you. I think it's a hidden slide. If I can just escape, I'll show you. If we have a lot of time, do we have a lot of time?
3 minutes.
3 minutes more. Okay. So, okay, yeah. So I had hidden this slide because. So this is iris hooks. Look at my iris. I have not finished my capsulorhexis, and it's a fishing net. Horrible iris prolapse. I'm not a bad surgeon. So, this is what. I can't put my phaco probe in. Look at that iris prolapse popping out from the side port. It's iris hooks. But I have safe visibility. I have enough visibility to do my surgery safely. Yes, now you need to deal with that iris prolapse. Every time you put in a device, put in your the phaco probe or the IOL, you need to protect that iris which is from prolapsing at the incision with a side port instrument. Take it in, draw it in. Now I'll show you iris prolapse with the BX. That was iris prolapse with the hooks, right? So I'm not claiming that the BX is great. Look at what I'm having. Look at it logically. What has the device got to do with iris prolapse? The part of the iris which is prolapsing has got nothing to do. You're not doing anything with your device over there. So it's the how floppy and how sail-like that device, how patulous that iris is it's going to prolapse. So between two hooks, what is the nature of your iris is it's going to prolapse. So it's up to you. So as long as you have constant visibility, concentrate on the surgery, and I think that works well. So we were there. So. Yeah, so no credit to pupil device when you don't have iris prolapse. It's just lower grade IFIS that day for you. So if you're having an IFIS case, what you need to do is use a device which goes in through a small incision and comes out through. So iris hooks are great, and the BX probably would be there. So it depends upon your choice. I'm not advocating either. No other device, no other pupil expansion ring can come out through a 1 millimeter incision side port. So that is a huge plus for the BX. If you're using any other device, you will be struggling to take it out. This, in a tight situation, would be a blessing. So intraop meiosis, again, I would think you need a device which gives you visibility and assures you that you're not holding the capsulorhexis margin. Right? So with a Malugin ring or an eye ring, the part which engages the pupil margin is on the sides. With the top view, you just can't see what's happening over there. So you can accidentally hold the capsulorhexis margin. With a BHEX, what you're doing is you're holding those flanges and tucking them under the pupil margin, and the notches are visible. So you're pushing, as you push that pupil margin, you have instant confirmation that the capsulorhexis margin has not been engaged. And if you do engage, you just retract a bit and come back again. It's very simple. This is a wonderful video available at the American Academy website and by Dr. Michael Henry. And this is with a tube shunt, antechamber shallow, neovascular glaucoma. It's difficult case, very shallow anterior chamber. Single incision, the entire BX was in place and the pupil was dilated. We did a good surgery. Look at going it around the tube shunt. You can't do that with any other device. You can't do that with any. You have, see, the advantage is with the forceps, you have control at the site of action. With the injector, your control is much more remote. So you can do whatever you want with the flange. And forceps is so easy for us. We are used to using those micro forceps, I mean, for donkey's years. It's intuitive for us. Of course, taking out the BHEX is probably the child's game. Yeah, finished. Yeah. So choice of pupil expander in intraop meiosis is BHEX or iris hooks, very safe. Subluxate cataract, no two second opinion. It's absolutely iris hooks and iris hooks because it allows you kind of asymmetric pupil expansion, and I would like to see my subluxate area better than the other areas. So there is no doubt I would use iris hooks and probably use every clock hour hook in a subluxated area. I would strongly recommend that you go up and look up this particular PDF, which is available with video links. It's available on our website, free to download, and the 10 tips on phacoemulsification. This is also available free to download. Thank you very much for your attention. Thank you, Dr. Rohit. Thank you, Tushya.
So, in the meantime, when Dr. Tushya would now be taking up a very interesting topic, iris prolapse, what next? Dr. SUVEN, picking up the questions till do you ever use iris hooks nowadays?
Not in the last 10, 12 years.
So, you know, with whenever the anterior chamber depth is less, I think one advantage which you have not mentioned with your BHEX is that you can use it, you know, when you're using with the low ACP, you should use iris hooks when you're decide between iris hooks or malucrin ray. Because with malucrin ray, you have more endothelial cell damage. Since this is less bulky, plane is single, I think this indication can be added.
Is there, I've written some slides for paucity of time.
Yeah.
Actually, I've got 4 similar presentations.
Yeah.
If you've not seen my presentation on BHEX and small people in this conference, you've not attended it.
Yeah. Can we re-sterilize the ring?
Officially, no, it's sold as a single-use disposable device, but in India, it's obviously not FDA. So it is, yes, a lot of surgeons are using it after you re-sterilize, but I would not recommend that because it alters the mechanics. It's a very thin device, so the shape and the flexibility and everything gets altered. So you may not get very good results, but if there's a cost crunch, of course you can. It doesn't cost something for you. Come on, the company has to survive.
Yeah.
Give me a break.
Yeah. One question from the audience. How many of us have iris hooks as their first line of action for small pupil? So, you know, so there is a good chunk, which I suppose in due course of time will reduce.
Yes, we should
But
change.
one thing which in iris hooks, whenever we are using, you know, one important thing which Dr. SUVEN said was the size of the pupil, 5.5 is more than sufficient.
Bilkul.
So when you are dilating using the iris hooks, don't dilate it more than 5 or 5.5. Because that will cause the advantage would be that will cause less distortion of pupil in the postoperative period. So don't dilate it to more than 5.5. So I in the initial stages, I used to dilate it more.
Exactly.
And when we dilate 5.5, we realize that the pupil remains almost the same. Am I right? Dr.
Absolutely, absolutely.